and uncorrectable refractive error.
You are melting the tip of the haptics. Then
Yeah, tip of the haptic, just heat it, sir. That there is a low heat cartridge there. Just it becomes bulbous, then push it through the conjunctiva. In the track it will go. Very nice, it will stay.
It will not slip away. It will
no,
not,
no, sir.
Forms a bulb.
Bulging there.
Yeah.
So I would like to take this opportunity to thank all the faculty. All of them had excellent videos. Very nice, actually, such beautiful, clear videos. Just seeing those videos, you can learn so much thing. And one thing about JP I would just like to add was he is a person who keeps innovating. So a lot of new techniques he will come up with. He won't follow the, the chosen path. He will keep thinking laterally. Like one tip he said was to make a small capsulotomy in the periphery to prevent capsular distension. I don't think that is mentioned anywhere. It is his own innovation. So that is, I think, one thing that we have to learn from such people is we have to keep thinking out of the box. So with this, we come to the end of this instruction course. And I would like all the speakers I would like to give the certificates. Yeah. I request Dr. Chandrakant sir to please hand over the certificate and memento to our guest faculty, Dr. J.K. Reddy. I request Andreas sir to please give the certificates to the other faculty. Is that? Okay. Fine. Right. Thank you. So one photo. Morning again. Actually, Dr. Sreeni is the chairperson. He is, I think, stuck up in another hall. So I thought I'll just start it so that we did not waste time. The next instruction course is Phaco emulsivation, learning from the masters. So we'll start, sir. Yeah. Our first speaker is none other than our immediate past KSOS president, Dr. Arup Chakravarti, sir. He will be speaking on Phaco dynamics. Over to Dr. Arup, sir.
Thanks a lot, Anup. Can I have the timer on so that I can keep a tab on my time? Timer, 10 minutes. Yeah. So, friends, I have used all these machines that you see on the screen, and what I would like to start off by telling is, you need to understand your machine extremely well. Can I have the timer on? Because each machine is different, and whatever parameters which you use for a particular machine, that just cannot be reproduced in another machine without knowing what that machine does. Okay, so I'll be focusing on two Phaco machines. I'll show videos, and I'll show how I adjust my parameters in those situations. Okay. Now I use from the Goider S3 VIP and the S4 machine, and then also Centurion. So the first case is a patient with a black cataract. All right. So whenever we talk about Phaco dynamics, it is basically to evaluate how you perform in extreme situations, in complex situations, like a very supra-hard cataract or a very soft cataract. So these are the situations where the best can be brought out of the surgeon as well as the machine. So now here I'm going to do a stop and chop technique. This is a technique which works quite well in many situations. It's not something which is pushed to the dustbin of history. So this is, I start off with sculpting. And if you see my parameters here, I don't require a very high IOP because I'm not working with a high vacuum or high aspiration. But I require a torsional. I set it up at 80% or 90%. And this particular machine with the balance tip has an amazing cutting power. All right. So hard cataracts, 70% to 90% torsional power, it enables you to cut the nucleus, to sculpt the nucleus with great amount of ease. So as you see here, let me show you the video. I start cracking the nucleus. There's no violent movements involved. We look at the lateral separation. We look at the line that develops here, crack line, and then you sort of, you bring it to the proximal area. Instead of trying to separate the nucleus into two halves in one shot, this is what you need to do, okay? So if the nucleus, posterior nuclear plate is leathery, as it is in this case, you may have to sculpt a little bit more and go closer to the posterior capsule, and then you see the chopping happens, the cracking happens without any difficulty. So here that has happened, and I'm using basically the same parameters. Sometimes you see when you sculpt that there's a lot of lens milk that comes up, which means your aspiration is not good enough. So maybe from 26 I'll go up to 28, 30, 34, depending upon at what stage I am able to have a very clear look at what I'm sculpting. Then is the fragment, then is the chopping, all right? This is stop and chop. So here my parameters change, I go up to a vacuum of 700. IOP is kept more or less at the same. And aspiration again, depending upon what you require. So I usually go from 34 to 40, the flow rate. So with these parameters, if you see here, the chopping goes on extremely well. There is, I'll be using a lower vacuum if I'm using a short vertical chopper, but if I'm using the Chang chopper, which penetrates deep into the substance of the nucleus, my vacuum level need not be very high, because, then the vertical chopping happens pretty well, okay? So once I have divided the nucleus into multiple fragments, as you see here, and repeatedly the anterior chamber will be topped up with a dispersive OVD, that is important. And then the fragment consumption. For fragment consumption, again, my vacuum comes down because I don't really require so much of power, so much of vacuum to hold. I'm just going to consume. The flow rate may go up, and the Phaco power also comes down, because here you're just going to emulsify the nucleus and aspirate it off. So your aspiration is high. Vacuum really need not be that high, because if you're dealing with a high vacuum, then you may end up with surge. In fact, it is a myth to say the Centurion machine doesn't give any surge. No, you get surge with all the machines. So certain situations I see, if I'm experiencing some surge inside the eye, like post-vitrectomy eye, high myopia, then my vacuum level also will come down from preset 700 to 400 or 350, till I feel that I'm having sufficient anterior chamber stability. So that is it. And so this was the pre-op stage, and this is the post-operative day one. Patient is extremely happy. She had a vision of 6.6 uncorrected. Now going to the guided machine, I use both S3 VIP as well as the Megatron S4. So it is important for you to understand the machine extremely well, as I told you earlier. This machine has a stainless steel handpiece as well as titanium handpiece, which is very light. But what I've realized is that the stainless steel handpiece works best. And you must use, if you're using this machine, you use the Megatape. Megatape has 3 Phaco developing surfaces. So it is a level aspiration, level lumen. So as you see here, if big chunks are taken in, it is emulsified at 2 levels, so that ultimately the occlusion of the needle within the lumen of the Phaco needle is not going to happen. Then, so basically, I always use the Megatip, and there's a mini Megatip also that is available for 2.2 millimeter incision, but I prefer for very hard cataracts 2.8 millimeter Megatip. So for super hard cataracts, the Chang vertical chopper, and routine hard cataracts will be the vertical chopper. So now let us see this case. Now this is again a hypermature cataract with a hard nucleus. There's a tendency for the rhexis to run to the periphery, so it was salvaged. So I'm going for a direct chop. But before that, a little bit of pit is created deep into the substance of the central nucleus. So for that, I'm using a Phaco power of 80. This is just longitudinal. This doesn't have torsional, so Phaco power of 80. Vacuum of 90. You don't really require vacuum, and don't require much flow of 18. So once you have a good grasp, now I have changed the parameters now, and I'm going for chopping. So here the Phaco power has come down, then vacuum has gone up to 350, and my flow is 50 milliliter per minute. And with proper diligence, you see here, without undue manipulations, without being very violent or savage within the anterior chamber, you are able to develop a chop line which comes to the center, and I don't really attempt to bring it all the way down near the incision to have 2 halves at this stage itself. So 4, 6, 8 pieces, depending upon the given case, how hard the nucleus is, how deep the anterior chamber is, and all that. So it can be easily maneuvered. Now, if I feel that high vacuum is not an issue when you're chopping because you don't break the occlusion. If you're following a proper technique, the occlusion doesn't go away. So you don't really bother about surge in chopping if you're using good technique and a good machine. So once I have divided the nucleus into multiple pieces, as you see here, then I'll go for fragment consumption. There's some amount of chemosis that is happening, so that happens in spite of our best efforts. Even as I'm not a surgeon for 30 years, I still get this kind of issues, and they can be easily tackled. So now I'll be changing my parameters. So while chopping and when fragment consumption, I will not be using a continuous, I'll be using a pulse mode, about 40 pulses per second. And I'll talk about the parameters well. And then again, this is titrated. There's nothing hard and fast. These are the parameters I'll start off with, and I find that there's too much of turbulence. If there is not adequate aspiration, the parameters will be changed accordingly. So if you see at the end of the surgery, without any surge, the last piece is consumed. So the parameters that I have used actually for sculpting, 80% power, and it is a continuous longitudinal. It has a no bubble, no burn sleeve. So I'm really not worried about the wound burn. It has never given us any wound burn. Vacuum is 90, flow is 18. And then I will use a pulse mode when I start chopping. So here, if you see, cool flash is chopping. So I 40 pulses per second. Each pulse is set as 25 millisecond, 30% duty cycle. So on time is 7.5 millisecond, and off time is 17.5 millisecond. And the parameters are more or less the same. Only thing is the vacuum is dropped when I come for fragment consumption. Chopping a soft cataract is different entity because here you don't play with the Phaco power. You just play with the fluidics and the vacuum setup. So here I have just engaged the Phaco tip, allowed the vacuum to build up, and then you can really perform a chopping quite easily in these cases without using Phaco power. Because if you use Phaco power, you're going to cheese wire through the nucleus, and you're not going to get the nucleus divided into multiple pieces. So friends, you require whatever technique you employ, have a rock solid chamber depth. For longitudinal, I would prefer any day to have a mega tip design, which gives me a solid cutting ability, very efficient chopping. This tip also enables me to handle a soft cataract because it has a much larger surface area. Efficient, this machine has a dual linear foot pedal control. Efficient power modulation is possible, and no bubble, no burn sleeve. So friend, you must understand the machine well and use the parameters accordingly. And I'm sure you'll have very good results with different grades of cataract. Thank you so much for your attention.
Thank you, Arup sir, for that very illustrious presentation of managing a suprahard cataract. Sir, I would just like to ask you the mega tip which you showed. Is it like exclusive for use with the Guder machine, or?
See, a mega tip is a Goider patented design, and then Earthly also replicated it, and there are court issues. Now Earthly has got a different patent for it. So it cannot. It goes only with certain handpieces. It cannot be fixed with. It cannot be fitted with standard machines. Yeah.
It's something like a flared tip design, which is available in different machines.
That's a flare tip, but this has got a little different from a flare tip, because it has 3 ultrasound generating surfaces, 3 slopes inside.
Right.
So as and when a hard piece of nucleus comes in, the main problem with chopping a hard nucleus is occlusion of the lumen of the needle. So that is prevented, because even before the lumen is only 0.5 millimeter. So even before the nucleus enters 0.5 millimeter lumen, it is emulsified just before it enters the lumen. So I have come across occlusion even with this design, but much less compared to other Phaco needles.
Thank you very much, sir. Now I would like to invite Dr. Prabhu Shankar, and he is going to talk about his different incisional approaches and capsular access.
I think before starting Phaco investigation, I think incisions are very important, because your incisions go wrong, your fluid dynamics inside goes wrong, and then the surgery is going to be very difficult. So incisions during Phaco is very important, because the first step. So this is a uniplanar incision. So that is, you have a single plane. You make a single oblique incision. This is for Phaco. So you can either hold the conjunctiva, or with the side port you can just hold on to the eye, and you see I'm just going diagonally, obliquely into the eye, It's just a single planar incision. That is a single oblique slit with 2 openings, okay? So that's a uniplanar incision. In case you're not comfortable with the direct keratome entry, the next procedure is a biplanar. So you can use either a 15-degree blade or you can use a keratome. I'll show in both. There's a 15-degree blade now. So what you do is do a peripheral groove there, small groove, probably around 250 to 300 microns. Shouldn't go too deep inside the eye because the blade is very sharp. And now we can hold the conjunctiva and through that groove, just make another oblique slit and enter into the eye. So you have 2 planes now. So this is called a biplanar blade. In case you don't have access to your 15 blade, you can also use a keratome. So in the keratome, what you do is you have to just rotate the keratome down inverse, and the sharp tip goes down, and you make another small groove there with the tip facing down. Now come back to your original position, and with the side port assisting there, and you just enter the groove there, and just enter the anterior chamber. So you have 2 planes. This is biplanar. So you have uniplanar, biplanar entry, and both works well, whichever you can. And the next one is the triplanar incision. So we have 3 entries inside there. So now what I make is, now you make initial groove there with the keratome, turn down, and second you again make an oblique entry up towards the cornea now. You tilt the keratome up towards the apex of the cornea and go up. And now again tilt, see now you can see the dimple there now. The dimple goes inside. So this is triplanar. You have 2 slits and a single entry there. So you have uniplanar, biplanar and triplanar incisions. So, and make sure your keratome size is what your phaco tip size is, and don't. Next one is a paired incisions. In case you want to reduce, you have patient that has around 1 diopter of astigmatism, so you make another entry there exactly opposite 180 degrees for a paired incision. It helps to reduce the astigmatism around 0.5 to 0.75. Only still make sure the adequate visco in the anterior chamber. Some use the step before surgery, before starting your phaco, but ideally it should be done after insertion of the IOL so that there not be any turbulence in the anterior chamber. So the next is on rhexis. So the next step, important step is your rhexis. So this patient has a very good red glow. So usually I use benzcistosome as the 26 gauge needle. So start from one end area and just try to make around 5 mm rhexis, because adequate rhexis size is very important. Too large is a problem and too small is very difficult to manipulate. So roughly around 5 to 5.5 mm rhexis is ideal. So this with the red glow, you don't have to use any blue, and you can do a comfortable rhexis. This for normal like NS1, NS2 grade. So problem comes when you have a mature cataract. So mature cataract, make sure you stain it twice, a single stain or double stain. So there's not much of cortex leaking around, so I am comfortably able to complete the rhexis with a 26 gauge cystosome. And make sure you don't try to go beyond that 5 to 6 mm air zone, because that's the area where the rhexis tries to run off. So make sure your anterior chamber is deep, and now you can do a comfortable rhexis in a mature cataract. Next, in hypermature, so you know this fluid is going to leak. So what I've entered is I've connected my 26 gauge needle to a irrigation fluid. So you can see fluid coming out now. So you decompress the lens now, all the liquefied materials come out. So you can see the liquefied cortex coming out, and once the liquefied cortex comes out, you can see the hard brown nucleus behind it. So wait, and now with the flow, you can just try to do a rhexis. So in this one, once I'm just starting the rhexis, I'm able to, the superior area is okay. So once I cross the superior 12 o'clock and come towards the nasal side, that's time the rhexis tends to extend. See this? I've crossed the 6 mm zone now, and the rhexis is trying to extend, but somehow I'm still continuing with the needle. This should not have been done actually. I should have stopped and used a forceps. So now the opposite side I'm going now. It's because the hypermature cataract, the capsule is calcified, anterior capsule. See, I'm trying to pull, nothing's happening. So now I use the scissors, 25 gauge scissors, cut the other end, and with the 25 gauge forceps, now I go to the opposite direction with the adequate visco in the anterior chamber. So the anterior chamber always has to be deep. So now I hold with the forceps. So make sure you always have a good scissors, 25 gauge scissors and a forceps in their operating room, because it's all very important when you're managing a hypermature and mature. So now the exercise is completed. So don't try to go in the same direction, go for the opposite side. So one is the intermission cataracts. So to prevent the Argentinian flag sign, so what you can do is go with the 26 gauge needle directly right into the center with the bevel down. So you can see the aspirate all the loose cortex there now. So you're decompressing the cataract now. So you have enough space now. Then once you put a visco, adequate visco, then you can go with your mixture. But only thing is you have to use your forceps. It's very difficult to do with a needle, the capsulotomy. So make sure you use a forceps, either through the side port or the main port. I prefer to use it through the main port. It's easy to manipulate, because always you can use a side port. When you have a 25 gauge forceps or scissors, you can side port is very easy to manipulate. Only thing is at one stage you'll have to use your left hand also. So once you decompress the eye, you have enough space. The lens is not bulging up, so you can do a very good needle decompression for intermission cataract. So don't try to directly go. So this prevents the Argentinian flag side. You can complete a phaco. The last one is, what else you can do? You can do a punch rexis. So if you're very scared to put the needle inside, go with the phaco now. With the same settings what you do is a phaco. Now punch the anterior capsule. Give a single punch there. There is decompressed now there. So once it's decompressed, the rexis will not run off. And you can just come out very slowly. Then once you get a hold of the rexis, all the fluid has come out with phaco aspiration in one punch. Then you can always do a very small rexis initially. Then once the rexis is completed, you can always go for a bigger one. Thank you. So I think incision and rexis are very important to do for your phacos.
Thank you, Dr. Prabhu Shankar. So for that very beautiful videos. Dr. Prabhu Shankar, I think probably would be one of the rare breed of surgeons who's equally good in vitreoretinal surgeries as he is in anterior segment surgeries. His routine list is some 10-15 phacos and some 5-6 vitrectomies and scleral bucklings. So thank you, Dr. Prabhu Shankar. Unfortunately, Dr. Matthew Kurian could not come because he's not well. So I would request Dr. Minu Mathan, who is the fourth speaker, to talk about hydro procedures also, in addition to his nucleus management techniques. To Dr. Minu, please.
Mic is on, yeah. Thank you, Dr. Anup. Just now only I realized that Matthew has not come. So through some nucleus management techniques have been already told. So maybe towards the end or when videos come, we'll talk about hydrodissection also, because without a hydro procedure, it's not a good idea to do phaco. So my basic topic was the slides will go in this order, but then in between we'll talk about that also. Nucleus management techniques. So once you do a rexis, we'll need to do a hydro procedure and then take out the nucleus. That is the main purpose. So for that, we need to emulsify the nucleus or disassemble the nucleus and then take out. So no financial interest in this presentation. So first of all, this I have been telling repeatedly, we need to do this first. If you are a trainee or a young surgeon, you need to do this 4-quadrant technique. So for that, basically select a grade 2, grade 3 kind of nucleus. Parameters have been already told in the first talk. So we need to trench. So no occlusion, no high vacuum required. Deeper in the center, keep trenching. Maybe up till the rexus margin only is enough. You need not actually go beyond the rexus margin because it is very soft beyond the rexus margin. Once you go down further, you will start seeing red glow. When you start seeing brighter red glow, stop. So sometimes you may not be able to complete it well on the sub-incisional area, so rotate 180 degrees and complete on both sides. So at this point, you can divide it into 2 pieces, or we can sculpt again. The idea is to take out the central core nucleus, debulk, and then to create trenches so that you can be easily splitting the nucleus into pieces which can be later emulsified. This kind of occlusion should not be there. The tip mostly should not get occluded. So once you have 4, you can use either the same instruments inside the chamber with just irrigation, no aspiration actually required. or stop, put viscoelastic, use two other instruments from parasynthesis and split. Split should happen at the base of the trench, not on superficially, otherwise it will just open out like this without the base splitting. So make sure it splits. You can go round and round. You need not completely split in one shot. But just split a little, then go further down, split a little, slowly split. And make sure that the center part splits. Without the center splitting, these pieces are not going to come out of the bag easily. Once that is done, parameters was just told before. So we increase the vacuum level, reduce the Phaco power, and then consume these pieces if you are not able to chop at that stage. That is okay. Only use your second instrument to manipulate. So in different systems of either azial or longitudinal, you need to feed in the pieces, or you need to make the piece free at the tip so that it moves around freely. And surge factor, if you notice surge, especially towards the last piece, always bring down your aspiration flow rate and the vacuum, and increase your bottle height if you're getting surge. Surge is the one thing you need to avoid when you're closing on to the last piece. So then after this you should move on to chopping. So chopping will divide the nucleus into multiple pieces without the use of too much of Phaco power in the anterior chamber, trying to do a lot of trenching and taking out the pieces. So that is less stressful to the zonules. The tip is always at the center. You need not move close to the rexus margin, safer, and all those things. So it is chopping into smaller pieces and consuming the pieces which are fully separated. So we need holding so that it is immobilized to split, and chamber stability to avoid post-occlusion surge. See, post-occlusion surge can happen even while chopping and also while consuming the pieces. So if you hold a piece and then wait for the vacuum to build up fully, and then you suddenly emulsify, sometimes you can just lose hold very fast. And even while chopping, when the nucleus is being split, you may be focusing on the splitting, and the tip will get loose and the occlusion may break. Occlusion or break can happen at any point of time, because the level of foot pedal from 2 to 3 is a very subtle small area. So suddenly you may go down into 3 a little bit, and the held part may get eaten off. So choppers, there are a lot of choppers. Basically, you need a sharp chopper and a blunt chopper. That is what I believe. So inside sharp, tip rounded, long, short, all are there. But then basic requirement is this. That's why I use this. So you can vary the length according to the whether it is very hard or moderately hard. But a sharp tipped one and a blunt tipped one, just like your finger, which is sharpened and not sharpened. 1.5 to even 2 millimeters you can have. Appasamy makes this for me, no financial interest. Both sides are there, one chopper for all cataracts for me. And then I would say we need to gradually go from chop to stop and chop, so that you can still be trenching a little bit and learn the chopping part. So here I am trenching. So we take out the central nucleus part, and the central part is debulked, and also you get space. These are the two advantages of doing partial trenching and partial chopping. So I finished the initial trench well, and then deep enough so you can see the red glow brightening there, using two instruments at the base of the trench and separating. So one half is separated, I rotate. I don't insist on going back and doing it in the same shot. So make sure central parts separates well. So nicely it is separated. So now after that you can hold each instrument. Chopping settings were also described initially itself. So hold well without losing occlusion and without tilting, otherwise the nucleus will keep moving. You will realize that the hold is not good. So here again you can notice that when it's harder, you can have a wider trench. You can have even 2 tip width wider, so that the central is mostly debulked. So you have lesser nucleus to emulsify. After that, you need to, because you stay within the rexus margin, so that you can hold on to the nucleus well without going underneath the rexus or going to the periphery. So we'll move back, stop and chop. That's over. So Phaco chop, so we talked about all those. So for me, there are two types of chops: vertical chopping and horizontal chopping. So vertical is done for harder nucleus, firm to harder nucleus. The nucleus is held with vacuum, go in with a burst of energy, come back to level 2, hold there, and within the rexus margin, sharp topper, neck close to your adjacent to your Phaco needle, go in with the chopper, lift up with the phaco probe, maintain the nucleus level, laterally separate, and that's it. So you can see here, this is a fairly hard nucleus. So if you have hard nucleus like this, you can have a slightly larger. So here I'm just showing from the beginning. I think so we can, hydrodissection may not be that very nicely seen here because there is not much, everything. See, this is a 5.5 millimeter rexus at least. Don't do very hard cataracts with smaller rexus because we need space to split up, and also this, when you have very hard cataracts, remember the capsule is also brittle and it's also older people. So they can break open very fast. So here is the stage when I'm holding the nucleus and splitting the nucleus into pieces. It's in a speeded up version, so it's not done this fast. It's in double speed, so just to save time. So once the pieces are separated, we can take it on the go or finish off the chopping process throughout 360 degrees and then go, because settings change. But for me, I nowadays don't change the settings at all. So you can do like that also when you are experienced enough. But initially, it is good to chop first with the settings which we said before, and then move on to the quadrant emulsification settings and come to the emulsification part. So here again you can notice it is, you go into the nucleus, hold it well steadily, chop with the sharp chopper on the side, see, and separate fully, and the piece is free now, and emulsify it in the center of the center of this one. Here again, when your phaco time is on and the machine is going on for some time, use dispersive viscoelastic. You need not use viscode, very costly ones, and you need not actually use. You can use Indian versions which are similar to this and which work very well, or even HPMC at times, but then repeat stop phaco, add more so that it doesn't injure your endothelium, because your corneal clarity is the one which is most important on day one. So next comes horizontal chopping. Here we use the blunt chopper. So place the blunt chopper through the cortex under the rexus margin at the delineated equator of the nucleus, and then go into the nucleus, hold and bring those two instruments close to each other and laterally separate. This is the basic concept of this one. So it is very simple and straightforward like this. So here again, hydrodissection has been done. This is my blunt chopper. Nothing big about it. It's just a straight thing with the tip blunt. So initially remove off all the cortex and the epinucleus. Then you'll see the center nucleus well. Then you'll know how deep to go. Otherwise you'll get a wrong idea that you have gone deep enough, because if you leave a lot of cortex on top. So now a small trench. See, going to the periphery, keeping the chopper tip there, and support from this side. You can, in very soft cataracts, you need not even go into the nucleus. You can just support. Here I'm going in, holding with vacuum, staying on. I will have 5 minutes for the hydrodissection part. Even if I don't touch hydrodissection, I'll use 5 minutes more. So now once they have all separated, the emulsification part is the same. Hold them, bring it to the center, emulsify. So if it is longitudinal, use vacuum to assist and use lesser energy. If it is a nozzle, you use less of vacuum, keep the nucleus piece mobile at the tip, and emulsify with more of energy. So the concerns while mastering phaco is what I've been telling still now. The tip has to be more exposed so that you get more purchase and the tip remains within the nucleus. If it is not steadily held, it will happen like this. If you try to chop, it will keep moving and rotating. And the ideal instrument for chopping has to be selected. A sharper one for a harder nucleus and a blunt one for a softer nucleus. And the orientation and bimanual dexterity, how to use the second hand more effectively for the instrument which you are handling. So start using the Sinsky well with the second hand and learn how to use the second hand for other instruments. So we were being told about the soft cataracts because we think soft cataract is easy, but soft cataracts are not easy because the central, this is the problem. You try to just maintain a hold with a little bit of energy itself, it will eat off. So you rotate, you hold another piece. Again you rotate, it will lose. So you lose the central core and you get a bowl of epinucleus in the periphery and you won't have anywhere to hold, it doesn't come out, it keeps rotating inside the bag. My third phaco case as a trainee, I remember, it was this kind of a cataract. I was very cool, okay, soft cataract will just come. 1, 2, 3, 4, everything gone, center. Now periphery is not coming. I was scared to go to the periphery to catch it, will catch the PC. So I had to call my trainer to complete that. So he did it coolly. What is that move? What is that? So, but then initially we will think that it is soft. So if it is soft, this is the hydrodissection and delineated nucleus. So you place the chopper at the periphery and you support. You don't have to, you make a small burrow there. See, there is a burrow here. So in that burrow, keep the probe and be in 2, foot pedal 2. Don't use energy. And support it there and drag along your chopper. So this is called a push and a pull. And this is easy. Do it in a dilated pupil, a soft cataract, and you will see that this easily works. And here energy has not been used at all. Energy is started only after dividing the nucleus into pieces. This is one way. But classically, we all suggest do a narrow, deep trench. So now I can show you hydrodissection. So after a rhexis, take your empty chamber is shallowed a little bit, go till close to the equator. One wave goes, once the wave crosses the center, stop, debulk, press down, and another 1 or 2 waves into the nucleus, into the epinucleus, so that you get a golden ring, which is the hydro delineated margin, and then rotate with your instrument if you are not very sure. Because I nowadays don't do, because I'm sure that it will rotate. But beforehand itself, if you rotate, it's good, so that you know that the nucleus is rotating. So here you see that I take out the cortex and epinucleus and divide after doing a full trench in the center. Now go to the mid-periphery, not too much to the periphery. Hold with vacuum. Try to pull. It will keep coming. But just wait with the vacuum and hear the sound. The vacuum is building up, the sound you'll hear. And then ting, ting, ting sound also you'll hear if it's complete occlusion. So at that point, drag backwards. If you pull back without full occlusion, it will just break occlusion. So bring back and then get it into the center and emulsify. Again, hydrodissection, soft cataract. So the people all the time ask, how much should I inject? How fast should I inject? Keep the syringe outside, press and see, one jet of fluid should come, that's all. And how much is decided when you have a fluid wave. If a fluid wave goes and you see the fluid wave passing the center, stop. So, and I don't do within 180 degrees close to me. So, and also you don't go very much away from you also. So do almost 90 degrees or 45 degrees. See, this is how you dissect and delineate. So if you do further, you can easily bring out one pole. It is very easy. When you do a 5.5 rhexis, 5 millimeter, and it is a grade 1 to 2 nucleus, you can bring out one pole. This is called the Phaco salute. So you go behind the nucleus. This is very far away from the endothelium. Don't worry, nothing will happen. And so hold in the center and chop from behind. So it will easily chop. So it is the bringing it out of the bag problem is not there in this. Second belluai. Ipo erangi poda annulla style ulla bellanide. Appo hydrodissection also I have covered. So hydrodissection and delineation in soft cataracts, and in mature cataracts you don't need to do hydrodissection. It's all loose cortex. And in even very hard cataracts also a gentle one, because you don't see the wave and don't inflate it too much. You see the movement of the lens up a little bit, stop and decompress. Otherwise also the very hard cataracts will just like that rotate. This is one which I don't want to show. Again, hydrodissection and delineation. Golden ring. Always I ask PGs, why is the ring golden? Nobody will answer. I'll say go and find out and all those things. So this question is very easy to ask to, especially PGs. Why is it yellow? Why can't it be red color? First chop is always difficult. I should stop. This is too much of a thing. Hydrodissection is over and all the other choppings have been shown. So every case can be chopped like this, and if you don't chop also, you can take out a soft nucleus like this. Thank you very much.
Thank you, Minu. I think Minu had an arrangement with Matthew Kurian, I think. So Matthew didn't come deliberately. So Minu got 15 minutes.
Matthew Kurian, power. He's lying down at home, fever.
Thank you, Minu. That was really an excellent presentation as usual. So next I invite Dr. J.K. Reddy. He will be speaking on cortex management and IOL implantation.
Good afternoon. And this cortex aspiration and IOL implantation. This when you look at all PCR and PCR cases and take all the statistics from across the all, it's equal. The number of times the PCR happens in cortex aspiration or in the nucleus in phaco emulsification. So both are equal, and as surgeons becomes more experienced, surgeons if you take it, the PCR is more common in cortex aspiration than in nucleus management. So the cortex aspiration is equally very, so early stages of your learning, there is nucleus management. Then, so you have two types of systems in cortex management. One you have coaxial and one is bimanual. Now the most popular one is the bimanual, but unfortunately I don't use bimanual, so I am going to show you only about the coaxial system, which I got used to for the past 25 years. So the hydrodissection is the point where the cortex aspiration management starts. So once the wave goes, I will stop it. I don't do delineation, a golden ring. Indians like gold, so they want to keep on getting the gold, they want to see the gold. So they keep on doing gold. So you are left with epinucleus, which is very troublesome to manage if you create gold there, golden ring. So I stopped with hydrodissection. We don't do, even in our institution, none of us will do delineation and no golden rings. Just do hydrodissection and leave it. Cortical cleaving hydrodissection, that's all. So you don't need to go under the capsule, even just stay 2 millimeters from the capsule, just release the fluid jet, just inject, it will get dissected. You don't need to do like in textbook description, go under the capsule, lift and do it. No need. Just inject the fluid onto the capsule junction, it will happen. So then you are left with only with a little bit, no epinucleus, little cortex. And it's very easy to manage. Just one sweep, it will come. It will take around 15 to 20 seconds. That's all. You don't need to spend more than that time. If you do delineation, then you have see the golden ring, then you will be stuck with gold only. So sometimes there will be thin layer of cortex stuck to the posterior capsule. Just do a small hydro separation before you go for aspiration. Just separate it like hydrodissection, posterior capsule, because posterior capsule, taking higher tip to the posterior capsule, a little bit risky. So once it's separated, see the main trick is keep the tip, that opening at an angle. Don't keep it down, keep it facing above toward the anterior capsule, or a little bit with the angle, that's all. Don't go down like that. Then again turn it and take it. It's an unedited one, no speeding, nothing, normal surgery. So it takes around 15 seconds for a removal of the cortex. Then sometimes the posterior capsule will be bulging at the end of surgery. You see a bulge. Then use a viscoelastic, generally methyl cellulose, keep it, push it down, make it concave and do it. Just don't put the probe inside. So if the convex phase you have more chance of rent. And sometimes you will have a subincisional cortex. Here also it is a simple, just put a viscoelastic. Fill viscoelastic, takes another 20 seconds time, and viscoelastic, then take a higher probe. It comes very easily. It's not a problem at all. But only thing is you need to take another 20 seconds of your time. It's waste on the operating. But it happens once in a while, not every day, 1 in 30, 40 cases. Then cortex aspiration doesn't end with the cortex aspiration alone. Posterior capsule polishing is very important. With bimanual, it is very easy. In coaxial system, you have to use irrigation with a cannula and polish the posterior capsule. At least 5.5 mm capsule should be as much clear as possible as a cellophane paper before you put an intraocular lens. I do it in each and every case. My PCRs are highest with capsule polishing among all very different stages. So when it comes to the lens implantation, we have different systems. One is the pusher system, and one is the rotating or screwing system, and another is the silicon tip system. So here in these two systems, there is no silicon tip. The pusher is one hand technique, and in rotation system screw, when you have screw, you have to use both hands, but that's got the maximum control and you never go wrong with that. Whereas pusher, sometimes even with experienced hand, sometimes the lens just goes like a bullet. And the silicon system is usually used for hydrophilics, not hydrophobics, but Indian companies, a lot of companies, they are using hydrophobics also, silicon systems. So this is a preloaded system. So here we go inside the anterior chamber. Don't go too much because the lens itself is around 7.7 millimeter. So you rotate. This is a single piece lens, so it goes easily. This what I want to observe here is, notice here we don't support the eye with the second instrument in the side port, and don't forcibly push the cartridge inside the eye. The eye just the incision should be just enough to go freely. You don't support in the side port and distort the wound. So incision distortion is a bad thing. So I recommend you not to do that, and just the incision should be good enough to go. This is a incision assisted system where you don't enter into the anterior chamber. Just at the lip you put the cartridge and inject a single piece. These are all can be done with single piece lenses or hydrophilic lenses. You cannot do this technique for a 3-piece IOL. Always I keep the lenses vertically. That means the haptics, one at 12 o'clock and one in 6 o'clock. We found the least amount of dysphotopsia with this position. And there are some times the haptic gets stuck at the in the cartridge. So don't retract the plunger. Just support with take McPherson and hold the haptic and pull it. It comes very easily. So it just comes easily, then you can inject it. If you retract the cartridge, it will snap off the tip of the haptic. And same thing can happen with silicon tip also. Here when it happens silicon tip, you cannot pull. Even if you pull, it will get snapped off. So you have to cut it with a side port, with a blade. You have to cut the cartridge so that it will expand and gives a space, and open it up. And if you have a good assistance, ask them then to pull the trapped trailing haptic. If you just put the trailing haptic, it will get snapped off. We have to do everything again. This is a 3-piece IOL implantation. So here you cannot do incision assisted. You have to go to the anterior chamber, rotate the lens, and here is a little bit tricky. You have to rotate this way, anti-clockwise, clockwise. Each company has its own technique, but it's quite easy only, but it's a little bit like a magic. You have to rotate first anti-clockwise, then anti-clockwise, first inject, then inject that. And it's a nice IOL 3-piece in the back. So this is a very complex situation where they say that the analysis, if you try to reason it out, everything, and do a thorough analysis of situation and come to a conclusion, and there is no truth in that. So this is against the scientific teaching which we had right from our schooling. They say you have to take a situation, analyze it, and reason it out, and come to a conclusion what is correct. But very intellectual people, they say that's a wrong concept. It's always better you just see the situation and do it. Don't go for reasoning, don't go for analysis. Then the truth will be lost. Thank you very much.
Thank you, JK. See, JK is beyond this gold level. JK is diamond level. That is why he doesn't like gold. But then remember, golden ring is not good for a cortex aspiration part. But then it is safe for your nucleus emulsification, but use your Phaco probe itself to aspirate off the epinucleus also, which you have created, epinucleus bowl, which has been created by the hydrodissection. And the second thing is, JK was very elegantly showing the tornado technique of aspiration of cortex, going all around in one shot like this. But remember, if the vacuum is on, and if one part of the cortex is aspirated and the next part, if you don't catch immediately, the tip is open with vacuum, and it is easy that you catch the capsule nearby. So initial stages, please hold the nucleus, hold the cortex. After the hold is on, bring it towards the center, aspirate, then come back, and then go towards the cortex again, hold, and then bring to the center and aspirate. And once you're good at that, then maybe you can do this tornado technique of, I also like that. I also do that. I just keep the vacuum on, just keep the tip facing towards the rexus margin and go all around like this. Most of it comes off. But then this is the basic problem in that. So, Diamond JK. Thank you.
Next, I would like to invite Dr. Prashant Bawankule for his talk on management of traumatic cataracts. Dr. Prashant Bawankule, prominent anterior and posterior segment surgeon from Nagpur. So, over to you, sir.
Thank you. Thank you, KSOS, for this wonderful opportunity. Friends, I would be sharing some of the pearls of traumatic cataract management.
JK, you had shown that soft lenses with the soft-tipped injector, no? The silicon injector, where the haptic is getting stuck. So many times we get the haptic gets broken off. You said you can cut it somehow?
I told you, no, that's very common, that the trailing haptics will get 100%. I saw many videos, I saw in last time in Paris and Vienna, they have shown a lot of things, 10 videos, 10 all they broke it. There's no need to worry. Just stop it, take a blade, side port, cut the cartridge vertically, cut in 1 or 2 places. So then you pull it. First we have to release that compression forces between the silicon and the cartridge. Then once you release it,
I think Dr. Prashant is ready, no? Right.
Okay, thank you. So after the hiccups, here comes, one of the commonest reason of unilateral cataract in young, well, the classic ones are rosette or a stellate pattern as shown in the figure there. The typical things which you need to remember is that this is not a simple cataract. Many a times is it associated with various anti-segment comorbidities and sometimes with this posterior segment comorbidities which we should evaluate, because it definitely affects the type of a management which you are going to do as well as the prognosis. Evaluation of a cataract, one of the most important thing is whenever you don't see fundus, do a B scan, and you might be pleasantly or sometimes shockingly surprised to see a posterior scleral rupture even in a white eye. Or sometimes you have a choroidals or a retinal detachment, you have a lens drop, you have a foreign body associated in a situation of a cataract. Most importantly, it helps you in assessing the posterior capsular integrity and define who is going to take care of this. If the posterior capsular integrity, as you see here, is fine, well, it is a domain of an anterior segment surgeon. But if you see the rupture in the posterior capsule, well, you can see a nucleus here, well, it's no longer your domain, just refer it to a vitreoretinal surgeon for a proper management. So how do you manage? Should all traumatic cataract be operated? Well, if you have such a peripheral small cataract, a stationary opacity away from visual axis, you can just watch it. But if you have a central axis, it is leading to not only visual loss, leading to inflammation, leading to secondary glaucoma, well, this cases needs a management. Now comes the point whether we should operate it in a case of an open globe injury as a single step versus 2-step. Well, remember, single step surgery only, you should do primary repair and you should try to do it preferably as a secondary procedure, unless there is a case of it is associated with posterior segment injury, there is a fear of infection, there is a IOFB present, or the ruptured lens matter is causing secondary glaucoma or inflammation. In that cases, it is better to do. So this is a case where you see after primary repair, you are doing a cataract. We have converted the tear into the rhexis, and the cortex cataract removal is not very great. It does not need much brains, basically because the cortex is very soft. Well, in this particular case, we are doing 2 steps where first the primary wound repair was done. We had aspirated a bit of cataract cortex which was spilling into anterior chamber in the first go, and about 10 to 12 days later you do. The advantage is you can do a definitive scan in a better way, or biometry can be done in a better way. Secondly, you are more sure that there is no evidence of inflammation, that fear is always there. So how do you tackle traumatic cataract? Well, you have these options, the IOL implantation options, we will come one by one. Lensectomy should be thought along with a repair or later on whenever there is a posterior segment involvement, either in the form of a foreign body or the nucleus or the lens fragment has gone, or there is a evidence of inflammation. In this case, the procedure of choice is going to be lensectomy. Well, in majority of the cases, if there is no posterior segment involvement, well, phaco emulsification can be done. Usually it is soft, simple irrigation aspiration can be the way to do. Where do we place? Avoid antechamber and iris claw lenses in a case of a trauma, because post-trauma, if there is an inflammation in such a case, you cannot really know whether it is infective or inflammatory secondary to the irritation to the iris. So let's see the challenges in a traumatic cataract. The challenges begin right from the biometry, because the corneal tear is there. You cannot do an adequate keratometry, neither can you do an axial length measurement, and then you have to trust the other eye if it is an emmetrope. So in such cases, if the other eye is not emmetropic, you are not sure about it, well, you can do just a phaco emulsification and then later on do a secondary IOL implantation as a secondary procedure. Now let's move on one by one challenges right from anterior to posterior. What happens in a corneal challenges? Well, you have a central corneal or peripheral corneal opacity like this. Well, it is a simple thing. While in a second case, it is a sclerotic cataract where the whole cornea is smeared with endothelium is smeared with the thing, and then the challenge is there. In such cases, a 3D visualization can help you. Or in a central corneal opacity, again, under the good glow, you can manage. It's a matter of tough. You should always refer it to an experience. Iridocorneal adhesions can be sprayed with the help of a visco expression using a simple visco cannula or with a irrigation aspiration port, and has to be done after you take care of the cataract. Now regarding the pupillary challenges, yes, you have a posterior synechia like this. You use a visco expression. You have to use multiple combinations. Push a visco dye there, separate the pupil which is adhered posteriorly, as well as this was a more than 6 months old means a foreign body case. And then you put a hook, and then the rest steps were all simple. Capsular related challenges, if it's an anterior capsular tear, well, you can just convert it into a rhexis and take it to your advantage, avoiding previous sneak. While sometimes you have a capsular fibrosis of this extent, you have to bypass the capsular fibrosis and try to get as far as possible the amount of the rhexis which you can aware. Well, this is another case where you can see it is capsular fibrosis is associated with grade 5 cataract with a you also have what I should say, a foreign body behind. So after bypassing the thing you could do. And in this case, you again see here the capsular fibrosis was extending quite up to periphery. So we had to use a Vanna Caesar to cut, and here we could not get a rhexis ream, but at least 3/4 of the quadrant it was possible. This is another challenging case which was a post-traumatic capsular fibrosis, grade 5 cataract. I will just come to the important step of it. See, after removing the cataract, we saw something like a calcific ring all across. We tried to chive it with the cutter, it could not be cut. So we had to use a Visilon and then push it out and bring it out. So certain surprises you would be getting inside a traumatic cataract. Now posterior capsular challenges, well, here we were sure there was a posterior capsular rupture, just did a irrigation aspiration. Here you should remember the bottle height should be less. And then this is where it was a doubtful rupture in this particular case. So the moment we try to do hydrodissection and delineate, it subluxated behind. And so is the importance of doing it in a complex setting where you have a vitreoretinal surgeon with you. You finished off the lensectomy, and then we put the lens in the sulcus. So this is the one classic case who presented with secondary glaucoma following shuttlecock injury. B-scan, how it helps you. We could see the nucleus over just behind the capsule. And what we did is we directly went behind, did a vitrectomy, we removed the lensectomy, and then on the support of the anterior capsule, the lens was placed, and then we did a primary posterior capsulotomy in this case, and the pressures also came down. This is pre-op. Sometimes because of posterior segment involvement, you do not have a glow, and that is another challenge. And here you can use various techniques like putting a chandelier posteriorly to have better illumination, use of dye. And sometimes you have to really use a 3D systems which have various filters which allows you better visualization. Now lens position related challenges can be in the form of subluxations, as you see in these videos. Well, you can use a CTR and various things. Sometimes traumatic cataract is also associated with other morbidities. Here you have a vitreous herniation in the antechamber. So before you do a rhexis even, you have to do anterior vitrectomy under visco, and then the rhexis and all steps are managed, rest were all easy. Sometimes a traumatic cataract is associated with an iris abnormality. Here the most important thing is you have to prevent this iris, get away from the active port, finish off the phaco, put the lens, and even this iris abnormalities have to be tackled. And here I am putting back the iris, inserting the iris root back into it with an inoprolene suture, and you can see this is the pre-op and this is the post-op picture of this particular patient. This is another extreme case of traumatic tear with a disinsertion, and this is a post-op picture of this. So simultaneous management, another case where we had subluxation with a total 360-degree disinsertion of iris root, and this is the post-op picture after doing lensectomy vitrectomy. Sometimes it is associated with posterior segment morbidity, so you do lensectomy and then you do a vitreous surgery. You have to combine it at a total and then do a siliconal surgery. And so I will just come to it for want of time. And so this is another case where we had a foreign body along with it. So after doing a cataract removal, the foreign body was, this is not playing, yeah. So after doing a cataract removal, the foreign body was picked up and it was brought out through the anterior segment. Yeah. So friends, traumatic cataract is a gamut of pictures put together. Remember, it's many a times you are fogged by simple white looking cataract which will be obvious, but many a times it is associated with posterior segment and other morbidities. So preferably it should be done in a setting where you have a vitreoretinal surgeon sharing the theater with you. Thank you.
Thank you, Dr. Prashant. That was a very nice talk. Beautiful slides and beautiful videos as usual.
Thank you, sir.
Yeah, he is also the person who has pioneered 3D VR surgery.
Thank you, sir.
Yeah, thank you, Prashant.
Dr. Prashant, see, if somebody, you can speak on the mic, please. If somebody sutures the cornea and then sends to you that there is and telling that there is a cataract and operate, how early do you operate? What should be the protocol when you see a corneal tear with a traumatic cataract? Either anterior capsule is open or a localized tear, cortex is in the AC, cortex is not in the AC.
So preferably if it is a clean cut tear, it's a fresh tear where I am sure that no foci of infection has gone and the visual axis is quite clear, I would do it as a primary procedure in a single step. That means I would repair the eye, I might do a cataract surgery. Whether I put a lens or not depends upon my doing an indirect ophthalmoscopy on a table and then doing a secondary IOL implantation if need be. In cases whenever there is an inflammation quite significant enough, you should always think that there is some needles of infection, and in such cases it is preferable to avoid putting a lens and putting it as a secondary procedure. Thank you.
Thank you. Next, I would like to invite our dynamic and highly energetic Honorary General Secretary of the AIOS, none other than Dr. Namrata Sharma. Madam will be speaking on phaco emulsification, see the unseen.
Thank you so much. At the outset, I would like to thank the KSOS and the entire organizing committee of Drishti 2022 Calicut for having us here. It's really a wonderful venue and a great scientific program as well as hospitality. I would be talking to you about phaco emulsification, seeing the unseen, and there are no financial or proprietary interests. So basically, you have this intra-op OCT microscope. In the same piece, you can see both your surgery as well as the OCT. So when you do make a main port, you can see where the main port is, and when you do the rexes, you can focus onto the lens and see where the capsular rexes is. The flap can be seen, and this is of importance, especially when there's a fibrosis present, which can be picked up, and also in cases of corneal haze. Also, when you do hydrodissection, the wave of fluid can be seen after you do the hydrodissection, as in this case. And this is again of importance in cases of posterior subcapsular cataract or posterior polar cataract, where you can see whether the PC is communicating with the vitreous or not. Then when you make a crater, you can actually see the depth of the crater by looking at the edges of the crater. So this is the hydrodissection wave which can be seen. And once when you start doing phacoemulsification such as here, you can see the depth of the crater, at what level you have reached and how much of the cortical plate is left, and whether you need to sculpt further or not. Then this is the whole epinuclear or the cortical plate which is moved up, and so when you push it down with the viscoelastic, it does go down. And then subsequently the cortical aspiration can be done, and again this bulge comes up just prior to the implantation of the intraocular lens. And then PC is quite intact here, which can be focused. Again, in cases of corneal haze, it becomes of importance because you can see it. Now, when you're putting the intraocular lens, implantation is being done, then you notice that the wound is completely open at this point in time. And there is this gape in the wound, which is present at the time of intraocular lens implantation, which can be seen here. And then after putting the lens inside, you can monitor the capsular gap after the insertion of the IOL between the PC and the IOL. And when the viscoelastic is there, then this gap is going to be increased. But when you aspirate the viscoelastic, the gap, it decreases between the PC and the intraocular lens. And this helps you to know whether the viscoelastic has been completely aspirated or not. Then when you do the wound hydration, the spindle of the wound hydration can be seen. such as this, and you can also make out whether the anterior part is opposed or not, posterior part is opposed or not. Sometimes you do have wound site desmet membrane detachment, which could be there in the main wound or could be there in the side port wound. So you can see there's a small DMD which is there. So at the end of the surgery, one can put in an air bubble so that it gets attached, because otherwise it is not seen because of the hydration, it is not visualized. So these things can be picked up on the intraop OCT microscope. This is the port side DMD, which you can see is present over here, and then at the end of the surgery, the air bubble is placed and this gets attached. Now there are different situations such as this, a posterior subcapsular cataract, and the PC is quite intact, so there is no confusion here at all. But when you have a posterior polar cataract, again you can make out whether the PC is intact or not, or whether it is communicating with the vitreous. Then in cases of white cataract, you can see that there are black fluid spaces which are present, and as you give a nick in the overlying capsular axis or capsule, anterior capsule, then there is no fluid which is going to come out because there is still, the intralenticular pressure is not that high. But when you do it in some other kind of white cataract, notice that this is completely featureless, and as soon as you give a nick in the capsule, there will be a blob of fluid which will come out. So again, it will help you to plan your surgery by just looking at the characteristics of the lens here. Now this is a case of posterior subcapsular cataract, and notice when you do the hydro dissection, there is a gap which is now separating the PC from the overlying cortex, and this is how it will be seen. But when you have a posterior subcapsular cataract like this has got a moth-eaten appearance, it is quite irregular, and this is communicating into the vitreous, so you can plan your surgery beforehand only, and you know that you may require a 3-piece IOL in such cases. We did look at the quantitative analysis of gap between the IOL and PC using MIOCT in eyes undergoing Phaco, and this depends on the size of the capsular bag and also depends on the type of the lens, whether plate, haptic or 3-piece. Then in cases of corneal haze with synechia, there's a synechia there, so when you release the synechia, you can see that it is released in a real-time picture, as well as, again, in this case, the pupil was enlarged. And as you do the rexes, when you lose the edge of the rexes underneath that haze, you can actually pick it up from the intraop OCT microscope, because the flap can be seen here, and that same flap can be picked up from underneath the haze. The case was, of course, completed, and an intraocular lens was put, following which a pupilloplasty was also done because there was presence of haze. Then in capsular distension syndrome, again, it is of immense help. There is a phimotic capsule which is present here. So in this case, this phimosis was relieved after putting viscoelastic above and behind this phimotic ring with the help of the ILM peeling forceps. And again, notice that there is a gap because there is viscoelastic, and the capsule becomes kind of crinkly because of the viscoelastic and the fluid which is entrapped here. So once this is done, the fluid is then aspirated, and when you do that, this comes bang onto the lens, comes bang onto the capsule, which again can be seen on the IOCT. This crinkly thing will move up, and then you know that the entire viscoelastic is out. And the lens is sitting on the PC, and notice how this crinkly thing is moving up and is getting opposed to the posterior to the lens. Then in cases of posterior polar cataract such as this in a child, only hydrodelineation was done, no hydrodissection was done, but you notice that you can see that there is herniation of the posterior capsule behind. And so you know that you may have to put a 3-piece IOL in this case. This was converted, of course, into a posterior capsular axis. And then, again, you can see the PC and the anterior capsule and the posterior capsule there. And a capture was done. When you do a capture, both the capsules will appear taut on the intraop OCT microscope. Now, this was a case where flax had been done, and notice how the capsule of the flax gets doubled on itself. And just at this point, there was a rent which occurred, and when this rent occurs, you can actually see the scroll of the PCR. So with the scroll of the PCR is concave, you know that this is not a complete vitrectomy which has been done. So once you do the vitrectomy, the scroll of the PCR, which you see, this is called as the scroll sign, will become concave, and then you know that the vitrectomy has been done because the scroll is now looking at the vitreous and not looking at the cornea. Then again, in cases of desmetopexy like this, when you have a Desmet's membrane detachment, you put the air bubble and you think you are done. If you didn't have this, you would probably think you are done, but you're actually not done because there's still some amount of detachment which is there. And as you put that pressure for good 5 to 7 minutes, it clears on the table itself with the external massage. And I think this is something that we all should do. And as you come out, again, there is some amount of detachment which is there. So always put some pressure there or put a blob of viscoelastic as you come out so that the air or the gas doesn't come out with you. Now, when you're doing lamellar grafts and you're doing surgeries, then whenever this case was uneventful, except at the end of the case, end of the surgery, notice that this is now moving, the DSEC graft has moved. So these subtle things can be picked up on intraop OCT microscope and you can see them and in the end can address them so that the graft gets stuck to the back of the cornea. Now again, this is an extreme case, a post-DALC phaco which was done, following which there was a detachment. Air bubble is instilled, so the detachment has decreased, but it is still not there, and you can see nothing because of the corneal haze that is present. And so in this case, the external wound drainage was also done, and then air bubble was instilled. So when you combine both, now the Desmet's membrane is quite stuck to the back of the cornea, and this clears up in the subsequent period. And this is the last video. A surgeon, the case was referred to us, the whole disc came out. He was doing phacoemulsification, and the surgeon put the disc back, hydrated the wound and sent to us. And then 2 hours later, we just had this disc, the patient's own Desmet's membrane disc, and we didn't know which side is up. So we looked at the intraop OCT microscope and saw that the curl upwards has to be there. That means the endothelium is down. And with that configuration, we were able to stick this or cause the apposition of the patient's own Desmet's membrane disc to the back of the cornea. And I call this auto-DMEC because this was the patient's own Desmet's membrane. So this is our publication with Professor Tityal on IOCT in anterior segment surgery. And to conclude, IOCT helps to refine the steps in phaco surgery, helps to see the unseen, and helps to understand the intraoperative dynamics during the phacoemulsification procedure. Thank you very much for your kind attention.
Thank you very much, madam. One query on this. Which all microscopes can this be attached to? It will go in any microscope? Or?
As of now, it is integrated into the operating microscope. So the Zeiss microscope has it, but I know that there are others also. In fact, even Appaswamy microscope is now has this intraop attachment, OCT attachment, which they're trying to make. So there are Indian companies also which are trying to make, but this is on the Zeiss microscope.
And you have any idea of how much it costs? I don't know. I know you don't know. Maybe it is a...
No, I know the cost, but the cost is, of course, very high. It is the cost of the operating microscope plus the cost of the OCT combined together. And I'm sure that with the time, even our own companies are going to make it, and the cost is going to come down.
Thank you, madam.
If you want me to say the cost.
It's nice to see all these unseen things which happen while we are doing surgery, you know. So, thank you very much. So we'll call upon the last speaker, Dr. Rajesh Sinha, again from RP Center, Delhi. He's we just met last 2 weeks back in Trivandrum. We had come for a talk there. So he would talk to us on tips and tricks for best results in pediatric cataract surgery. While he's setting up things, I just wanted to mention one thing about the injection of IOL, which we saw Dr. JK showing, and this cartridge getting split up. So we get into a soup when you are doing a hydro implantation in such situations. If it is viscoelastic, it is fine. But if your one hand is not free with hydro inside, and then you get a split or the haptic gets stuck there, then you're stuck. So either you will have to keep the lens down, because if you take the irrigation out, the chamber will shallow. So get the this one, sodium hyaluronate, very fast, or get somebody else to hold the lens and use your second hand, third hand to fill up the anterior chamber so that the lens doesn't come and hit your endothelium. Thank you, sir. You can carry on, sir, please.
Thank you, Dr. Minu, and thanks Drishti and KSOS, Sreeni, and the whole team for having me here. I'll be talking about the tips and tricks to improve outcome in pediatric cataract surgery. Now, the most important thing that we all know is that in pediatric cataracts, the capsule management is really tough, because capsule is very elastic and it has a tendency to go outward. So you have to have a centripetal force so that you can create a circular capsular rhexis. The nucleus is quite soft. As you can see here in these pictures, all these pediatric cataracts, aspiration of nucleus is not a big issue. But post-surgery, posterior capsular opacification is something which is a major concern. It can manifest in various forms like this. You can have thick fibrotic membrane. You can have phimosis of the anterior capsule. You can have even the decentration. Sometimes when the anterior capsular margin is not overlapping nicely, then what happens that the iris can have a synechia because of inflammation in these cases with the capsule. There can be decentration and optic capture of the IOL. So all these things can happen, and PCO is something which can have a very diverse presentation and very significant implications. So most of the pediatric surgeons have now, it is an established fact. They agree that we have to do a posterior capsular rhexis in all these cases. So these are some of the data, like in less than 2 years with PCC, even then you can have a 10% chance of visual axis opacification. But if you don't do PCC, even in somebody more than 2 years, 2 to 8 years, 83% is the chance of PCO. If you don't do PCC, most of the cases will have PCO. So this is how we would like to do in pediatric cataract cases. Sometimes the pupil may not be dilated fully, so you have to inject a little bit of intracameral adrenaline. Before you are doing that, you have to tell the anesthetist that you are injecting that. And then it is good to stain the capsule with the trap and blue dye, not only to have a better visibility, but also to make the capsule after staining with trap and blue dye becomes a little less elastic. This is what we have observed. And then, as you can see here, the force of the capsular rhexis forceps is centripetally. So you have to have an inward force so that you can create a circular capsular rhexis, and then hydro procedure is done so that you separate the cortical fibers from all sides. Aspiration of cortical fibers is not such a big issue, as you can see here. It is very easily done. But still, in spite of all these, sometimes you can get some fibers. So if some fibers are there, then you need to remove it, because these fibers will proliferate and cause Sommering ring in future. Then posterior capsular rhexis should be done by injecting a little bit of viscoelastic. Don't overfill the chamber with viscoelastic. And then once you have done the posterior capsular rhexis, you try to center it, because that will coincide, the opening and the clarity of that area will coincide with the center of the IOL. So this is how we should do it. A central anterior rhexis with a central posterior rhexis, and anterior vitrectomy is done. And then inject some viscoelastic, high viscosity in the bag, and then inject the IOL in its position. So once the IOL is there in the bag, you remove the viscoelastic. You can use a vitrector to remove the viscoelastic by IA cut, keeping it at IA cut mode when you are above the IOL. And when you are going behind the IOL, you can use the cut IA mode so that you don't cause any traction in the vitreous when you are removing the viscoelastic from behind. So once you have done that, you position the lens back into the bag nicely, and this is how it should look like. Nicely overlapping anterior capsular rhexis margin with a central posterior capsular rhexis. Now, if you are keeping the patient aphakic, then in that case you can do a posterior capsulotomy even with a vitrector, and you can do it very easily. Sometimes you have a posterior polar cataract in these children. A few children have noted that there are pre-existing defects in these polar cataracts. So in these pre-existing defects, it is advisable to round it off and convert it into a posterior capsular rhexis, so that you can place the IOL in the bag with a nice central clear visual axis. Do an anterior vitrectomy, remove the viscoelastic in the same manner. As I said, using the cutter really is very helpful in removing viscoelastic from behind the IOL. Sometimes, in spite of all that, as I said, there can be visual axis opacification. So if you have a visual axis opacification in a pseudophakic eye with something, so much of fibrosis, then in that case, there are two ways of doing it. You can either go from anterior route or you can use the vitrector from posterior route. If you are not comfortable going from posterior route, then release the Sreeni from all sides and then go behind the IOL and create a space, inject some viscoelastic there, and then make a nick. And then after that, with the help of a vitrector and irrigation cannula in the anterior chamber, you can clear the visual axis completely. So this is how it should be done. But most of the times, if such is the IOL capsule complex, then many times I prefer using a combination technique, putting the anterior chamber irrigation and going from the pars plana region to do the membranectomy, and that clears off the visual axis very nicely in the end. One scenario I would like to add, one more scenario, and that is a case sometimes you have left the child aphakic, you have done a lens aspiration, kept the child aphakic. Then in such a case, sometimes you have very bad fibrosis of the anterior and posterior capsule. They merge with each other. Then there's a sommering ring all around. You can put a multi-piece IOL in the sulcus just like that because the central axis is clear. But what happens that because of the thick sommering ring, the haptic will be directed anteriorly and it will keep rubbing the iris tissue, and that will cause release of pigments. So that will cause inflammation. So in such cases, it is better to remove the sommering ring. So first remove this fibrotic element, separate the two capsule, and then remove this sommering ring from the peripheral part, and then put multi-piece IOL in the sulcus. Now once you have put the multi-piece IOL in the sulcus, it is advisable, if possible, to do a posterior optic capture. Because if you do a posterior optic capture, a big problem in pediatric cases is decentration of IOL if the IOL is not properly in the bag and not well surrounded by the anterior capsular margin. So in such cases, it is advisable if you are putting a multi-piece IOL in the sulcus to do the posterior optic capture. So in conclusion, pediatric cataract is a challenging scenario. Removing the cataract is not such a big issue, but preventing complications, and a big complication is posterior capsular opacification. That is a major issue. If you are putting a secondary IOL, you occasionally can open the bag and then put the IOL in the bag, but very often you are not in a position to open the bag because it may not open up entirely. So if it's not opening up entirely, it's better to put the IOL in the sulcus, and if you're putting the IOL in the sulcus, posterior optic capture should be preferred. Thank you very much for your patient listening.
Thank you, Dr. Rajesh. Generally, operating on pediatric cataracts is a big challenge. So you have touched upon all the aspects of it beautifully, on all the beautiful, very self-explanatory videos. Thank you.
Thank you.
Right. So I now invite the Chairman Scientific Committee, Dr. Sreeni. We would like to present some mementos to our esteemed guest faculty. Next, I invite Dr. Namrata Sharma. Yeah. Dr. Prashant Bavankule.